A brief introduction of myself. I studied biology and biochemistry in Tübingen. I am a geneticist, have a doctorate in serological genetics, then became head of the department for human genetics in Heidelberg, and was there forced to study medicine, because it was not possible to invoice the health insurances for family planning services, so that a pediatrician always had to sign the invoices. He didn't know what he signed, but did it anyway. My former boss, Professor Vogler, then told me that I had to do medicine. I was the youngest of the team, so it hit me. That is how I became a physician, although I hadn't really planned it. We have done a lot of genetic research in cooperation with the German Cardiac Research Center and have many links with the US. I am still keeping that up and visit the US approximately 6 times per year. We also have patients over there. We always try to stick to the motto, it was mentioned here this morning, learning by doing. Medicine is empiric therapeutics, using natural science without being natural science itself. So it makes sense to introduce also this kind of treatment to medicine. Just a brief detour to selenium, because it is important to me. The godfather of selenium is Professor Schrautzer from La Jolla. I was lucky enough to have met the gentleman. A colleague right at the back asked about large doses. I also mentioned the self-experiment. There is an area in central China with an excessively high selenium level in fresh water and an increased incidence of cancer. It was tested, and it keeps popping up in publications of the medical service, of healthcare insurances and elsewhere. Yes, there actually is something that increases the cancer risk. Since earliest childhood, they are faced with 1,200 to 1,500 micrograms of selenium per day in fresh water. Obviously, this is toxic. We require a certain measure of free radicals. Of course, it supports oncogenesis if I take them all away. Oncogenesis is in all of us. So it goes without saying that somewhere, sometime, an increase of tumor masses occurs. In connection with radiotherapy, you will also be told time and again, under no circumstances to administer selenium. The reason is that ionizing radiation triggers the production of free radicals to destroy tumor cells. Although radiotherapists nowadays are excellent mathematicians and have such excellent equipment that radiotherapy is relatively well-centered, many free radicals are still being produced for the remaining tissue. What is really so damaging, as my colleague has described so excellently with lymphedema and fibroid mutations later on, is the afterburning effect, which I am unable to prevent altogether, but at least to a certain degree, by administering the equivalent selenium doses. Then, there is the reduced incidence of prostate cancer. The background being that a silent inflammation can go undetected, but if the patient has a selenium deficiency, among other factors, 5–10 years later, cancerous mutations can occur.
Dann kann es unter anderem Selen, dann kann es zu sowas, dann kann es eben über Jahre hinweg, sprich 5–10 Jahre, kann es dann tatsächlich zu karzinomatöser Veränderung kommen.
It was important to me to mention that, and also the combination of selenium and zinc, or selenium and vitamin C. In naturopathy, zinc is also prescribed as a soporific. As long as zinc is taken at night, there is no problem to take selenium in the morning. Both with zinc and with vitamin C, selenium produces selenic acid. It won't be harmful to us, but it doesn't have a positive effect either. Therefore, it is important to differentiate. Administering selenium combined with zinc or vitamin C? No. But all 3 substances are excellent in biological oncotherapy. It was important to me to briefly mention that.
Das nur kurz erwähnt, war mir wichtig. Und über das, was ich heute referiere,
The subject of today's lecture is Artemisia annua, or sweet wormwood. Sweet wormwood is a substance which has been used in traditional Chinese medicine for 2,000 years. To this day, leaves and petals are used for tea infusions for the treatment of feverish infections. Sometimes unsuccessful, sometimes successful. Here, again, the motto is learning by doing.
Wurden als Teeaufgüsse benutzt oder werden heute noch als Teeaufgüsse benutzt für alle fieberhaften Infekte. Mit mehr oder weniger gutem Erfolg. Das heißt, auch hier Learning by Doing. Das chinesische Wort dafür ist Huanghua.
The Chinese term for this plant is Huanghua. The plant belongs to the family of Compositae, namely Artesunate. You can see it here, and is indigenous in China, some regions of Tanzania, and North America. The plant was somehow introduced to Europe, where it is being cultivated. Plant components are essential oils, flavonoids, and the component we are talking about here, artemisinin.
Über das, was wir heute referieren, ist Artemisinin. Artemisinin ist eigentlich ein
Artemisinin is a phytochemical which occurs in leaves and petals. It is characterized by its peroxide bond. You can see it here, and a trioxane ring. We will come to the peroxide bridge a bit later. I just wanted you to have a look at it.
Die wird uns nachher noch beschäftigen. Das können Sie auch wieder vergessen, nur dass Sie mal gesehen haben, wie sowas überhaupt aussieht. Und der Teil hier
This part down here is extremely important with regard to chemistry. The crude extract will be evaporated. We are then left with an oily, yellowish liquid, which is viscous. By recrystallization, it turns into white powder, which is artemisinin proper and looks like this.
Und das ist das eigentliche Artemisinin. Das sieht dann so aus.
Artemisinin has only a percentage of 0.1 to 0.4 of the dry weight of the plant, so it is not exactly a cheap process to produce it. Here you can see the molecular formula.
Summenformel können Sie ablesen, kein Problem. Und das ist immer noch Wasser.
At this state, it is still water insoluble. However, the substance contains subderivates, such as Artemisia, still being water insoluble. It looks like this.
Unter anderem das Artemeter. Das sieht so aus. Das ist immer noch wasserunlöslich. Und dann was
But then we also have Artesunate, and that is hydrosoluble. Here again, we have the peroxide bridge.
Brücke. Und wir haben das vor Jahren,
Many years ago, maybe 10, 12 years, we tried to import it from China, in cooperation with a dear colleague. Some of you might know Dr. Scheller. That was something else, I can assure you. We tasked several laboratories in Australia to examine deliveries from at least 10 different suppliers. The labs found the most horrible additives.
In Labors in Australien mit übelsten Beimengungen und dann nach langer Zeit haben wir dann
Eventually, we found a substance that was suitable for medical purposes. The Dr. Miller Company was kind enough to support us.
War dann so freundlich und hat uns da unter die Arme gegriffen, es musste so rein dargestellt werden und so stabilisiert werden, dass wir das auch
The substance had to be purified in such a way that it was not only suitable for peroral, but also for IV administration. So we really owe a big thank you to the Dr. Miller Company for their pioneering efforts in this area. It is not easy to find someone in Germany who is so open-minded about new approaches.
Weil es in Deutschland so was zu finden, jemand, der dann so offen ist, ist nicht ganz einfach. Die Chinesen benutzen
As I pointed out, in China, this medication is used to fight feverish infections. And worldwide, it is used as an anti-malarial therapy. It is an ancient substance when you think about it, but at the same time, it is brand new since all the findings and scientific information I will present you today date from 2010.
2010 stammen, auch wissenschaftliche Informationen, wenn Sie nur bei PubMed nachschauen,
If you type in artemisinin or Artesunate at PubMed, at least 200 to 300 of the latest publications will pop up. meaning that this substance is also prevalent in traditional medicine, and not only with regard to the treatment of malaria.
Und nicht nur in der Malaria-Behandlung. Über die Wirkweise sage ich gleich was, weil
I will tell you something about the therapeutic mechanism in a minute. We can then draw conclusions from anti-malarial therapy for oncotherapy.
Das Artemisinin hat die Peroxid.
The peroxide structure of artemisinin becomes unstable by iron, and free radicals are produced. The more iron a cell contains, the more aggressive the substance becomes. That is obviously crucial for anti-malarial therapy. Why? Plasmodia are contained in erythrocytes, whose hemoglobin contains a lot of iron. That means an increasing number of free radicals are produced. Artesunate becomes unstable and the cells are destroyed. Plasmodia are released and will practically be opsonized. They are being recognized by endogenous defense mechanisms and killed.
Die Zellen gehen kaputt, die Plasmodien werden frei. Und werden dann praktisch opsoniert bzw. also von der körpereigenen Abwehr erkannt und umgebracht. Und man hat
in Kenya, one of the most dangerous countries for tourists with regard to malaria, resistant strains against normal anti-malarial medication have developed. However, they can be treated with artemisinin. Thus, even resistant strains can be destroyed. Even with regard to Plasmodium falciparum, the most dangerous one of the lot, successful treatment is possible.
Plasmodium falciparum, was ja das der gefährlichste Teil ist, können da noch Erfolge erzielt werden.
8 weeks ago, a strain of malarial parasites were detected in Laos, which, allegedly, are resistant to artemisinin. This is being investigated, but the World Health Organization is involved in this. So, even the WHO has recognized this drug because it represents a real alternative with significantly fewer side effects than normal anti-malarial drugs. And it can be produced much faster, even in poor countries.
Weniger nebenwirkungsbehaftet ist wie die normalen Malaria-Medikamente. Und auch sehr viel schneller auch in ärmeren Ländern produziert werden kann. Before
we were given the opportunity to be supplied with Artesunate by the Dr. Miller Company, we used a drug from Kenya that was still oily for IM injection. We had to import it via Brussels, by a Belgian firm. We had to go through all sorts of contortions to make this drug available for a biological tumor therapy.
Es war ein Eiertanz, das Medikament auch für uns in der biologischen Tumortherapie erhältlich zu machen. Das heißt, wir gehen jetzt von den Tumorzellen aus.
Let's start at the tumor cells. From a statistical point of view, tumor cells contain significantly more iron than normal cells. Each cell is equipped with the transferrin receptor mechanism. The trouble is that this mechanism is much more active in tumor cells, meaning they smuggle an enormous amount of iron into the cell. Based on this knowledge, we are able to selectively damage them, and the cells, by producing free radicals, burst, so to speak. Why? The free radicals are produced in and around mitochondria, meaning cell respiration is directly damaged.
Das heißt, ich habe eine direkte Zellatmungsschädigung und damit das kann man auch Elektronenmikroskop.
This process can be observed under the electron microscope. The cristae mitochondrialis swell. The entire mitochondria swells and bursts, and thus the entire cell bursts. It's a pretty elegant mechanism which works in the erythrocytes against malaria. This became even more pronounced in the tumor cells. So, iron was used in many trials because the understanding was that it accumulates faster in tumor cells. We thereby have a high concentration of iron in tumor cells, which means we can selectively impair a larger number of them.
Von hohen Eisenkonzentrationen in Tumorzellen, somit werden die selektiv mehr.
The same is true for side effects. Each cell contains iron, which means normal cells are also adversely affected, but not as much as tumor cells. And that is largely due to the specific activation of the transferrin receptor mechanism, because considerably more iron is smuggled into the cells.
Wesentlich mehr Eisen reingeschaufelt. Professor Heffert vom DKFZ, also Deutschen Krebsforschungszentrum in Heidelberg.
Professor Effert of the German Cancer Research Center in Heidelberg published 2 cases of choroid melanoma late last year. They had reached an untreatable stage, meaning neither chemotherapy nor interferon had an effect. Nothing could be done. A really bad state. The choroid melanomae were chemo-resistant, had grown under chemotherapy, meaning they were untreatable. The patients had a life expectancy of a few weeks in a poor condition. Ein zu erwartendes Leben noch in bescheidenem Zustand von wenigen Wochen. In one case, there had been a primary complete remission of 24 months. But then the problem reappeared, and the patient left the study group and subsequently died of choroid melanoma. The other patient stuck to the therapy and was released as healed after 48 months under observation. Der andere, der da Therapie oder linientreu blieb, der ist nach 48 Monaten Beobachtungszeit, ist er als gesund entlassen worden. The cases have been published. The German Cancer Research Center is a highly qualified institute with a high national and international reputation, and it shows good results. So vorstellen, sondern also was auch gute Ergebnisse zeitigt. Let's have another look at the therapeutic mechanism. The peroxide structure of artemisinin becomes unstable by iron ions. This leads to the production of free radicals, and the cell bursts. Angiogenesis is thus obviously reduced. The normal growth of vessels towards the tumors is reduced, partly even stopped. I will explain in a moment when it can be stopped. Furthermore, we have a reduction of vascular endothelial growth factors, whatever the endothelium produces and where it ends up. We also get carbon radicals, which are able to cause DNA strand breaks, which then lead to apoptosis. So, we have 2 crucial mechanisms here. First of all, DNA strand breaks, and secondly, the destruction of mitochondriae caused by the swelling of cristae which burst, so that the tumor cell is beyond repair and thus irrevocably destroyed. So irreparabel gestört, dass ein Weiterleben für die Tumorzelle nicht mehr möglich ist. Ihr habt nur jetzt einige von den, das wären jetzt etwa 250. There are about 250 publications, but they would only bore you, because effectively they all lead to the same mechanism. You can always access them. They're all from 2010, I guess from the second quarter. Also from the Washington University in Seattle, from our colleague Morrissey, who researched cases of prostate cancer which were resistant to anti-hormone therapy, and by then also to chemotherapy. Normally, Taxotere is used in these events, occasionally also combined with the angiogenesis inhibitor Avastin. But the cancer was resistant to these substances and carried on growing. However, once Artesunate was administered in addition, cell arrest was achieved. So, we had a stable disease. Continued therapy with Artesunate even resulted in an improved repeat response. I will get back to the repeat response to chemotherapy later. In other words, the Taxol preparation triggered a response again, and the tumors actually improved. My colleague Michaelis from Freiburg University published in the magazine Anti-Tumor in January 2010 that neuroblastomae responded to Artesunate. These are tumors which A. are extremely chemo-resistant and B. extremely resistant to radiation. That is understandable when you think about it, since the more aggressive tumor growth is, the more iron it absorbs, and the more sensitive it obviously is to this type of therapy. A colleague asked me about plasmacytoma earlier. It depends. If a significant progress in the plasmacytoma is observed, that is really true for all types of tumors, we have a massive input of iron. In other words, I can use Artesunate at an earlier stage and have a more rapid effect.
das Artesunat schneller einsetzen, das heißt eine schnellere Wirkung. Und die bei zwei Patienten von Professor Effert.
Let's return to Professor Effert's two patients with choroids melanoma. Obviously it was tested, and the effects were identical if iron should be administered or not. In other words, in the event of a highly aggressive tumor, which is growing relatively fast, the tumor also absorbs a large amount of iron very quickly. So, Professor Effert demonstrated that it is not really necessary to administer extra iron in the event of such aggressive tumors, and that the existing iron overload actually contributes to the destruction. Can I administer iron perorally, since iron IV is very expensive? Yes, however, we only rarely do that now. I mean, we rarely administer iron at all, because the effect is there anyway. It will cost next to nothing to give it perorally. Yes, but it must be considered that iron is only administered for a short period of time. Most people can't take it very well anyway, when they have to take it perorally. It is very well tolerated together with vitamin C, since absorption is improved by 3 to 4 times. Correct. If it is administered, then only initially, so that a relatively large amount is absorbed by the tumor, and then I follow it up with artesunate. It also means that I have a high amount of iron for a short period. That will not harm the liver, and hemosiderosis or something similar will not develop. The liver is relatively well protected against it, because I only administer it for a short period of time. That way I can use it. The Guangdong University in China published a study in April 2010 on artesunate in cases of pancreas carcinoma. Pancreas carcinomae are also very aggressive, fast-growing cancers, which are chemo-resistant. They grew under chemotherapy. I've brought a case report. Artesunate was administered, however only IM. Anyway, the standard therapy became effective again. In other words, not only was it possible to stop the tumor from growing, meaning stable disease, but even regression could be proven, and the tumor became operable. A combination with artesunate is always crucial. It may not be a panacea, but we use it in combination with other biological methods, as my colleague mentioned earlier. And we can also use it in combination with chemotherapy. In addition, we can administer it during periods when no chemotherapy is applied. Most of you will know patients who are saying, okay, so nothing more can be done. And when tumor markers go up and the tumor grows, they say, do we try this or that? Second line, third line, fourth line chemotherapies are carried out without really showing an effect. But Gravett and other colleagues from London University were able to demonstrate that in cases of chemo-resistance and tumor growth, it should become standard to administer it, so that all of a sudden the tumor responds again. I must point out, however, that there is definitely a difference in the mechanisms. A short while ago, my colleague was talking about the T1C, the small mastocarcinoma. A G2. G stands for grading, the aggressiveness of the tumor. Our colleague Hacketal used to call such G2s pet cancer, because this tumor grows relatively slowly. G3 and G4 are more active than G2 in that respect. And we further differentiate. In cases of G2, which have been published up to now, monotherapies are described and have shown anti-tumor effects.
Therapien, die bisher auch publiziert sind, alleine genommen und haben da Antitumoreffekte gezeigt, und die wurden die G2er.
And G2, more often than not, were treated with iron prior to therapy. G3 and G4 we find relatively frequently in our surgeries. Those cases are more aggressive and grow even faster. In most cases that have been published, no iron was administered prior to therapy. That means it's not absolutely necessary. Around half of the tumours currently published are chemo-resistant tumours, and also hepatocellular carcinomae. That was revealed by Africans and Asians respectively, because they have a relatively high number of patients suffering from hepatitis B and hepatitis C, who, more or less imperceptibly, develop hepatocellular carcinoma. Such tumours are not highly aggressive, and there are relatively few chemotherapies having an effect at all. In most cases, the patient is relieved that he or she receives treatment at all, and the physician is relieved that he or she can administer something. However, the effect of chemotherapy on primary hepatocellular carcinoma is relatively small. But when combined with artesunate, surprising reductions have been observed, in particular with regard to primary hepatocellular carcinoma. I have another case report. The effect has unambiguously been proven, simply by the biochemical mechanism in malaria, indisputably. Resensitization was definitely proven for gemcitabine, one of the drugs most frequently used in pancreas carcinoma and hepatocellular carcinoma. What is extremely crucial is that it can be combined with chemotherapeutics. A new study was published in June this year. It shows that in colon cancer, the activity of mitomycin is possibly reduced by artesunate. It must, however, be pointed out that this study must be reviewed, which the authors of the study have mentioned themselves in their summary. However, the crucial point is that mitomycin does not really play a part in the treatment of colon cancer. We use mitomycin in hypothermia because it shows a stronger activity. To this end, we administer small doses of mitomycin to achieve relatively high cytotoxicity with hypothermia. This is the only hint of the possibility that mitomycin could impair the anti-tumor activity in the cell. Let's now turn to the application. We administer artesunate intramuscularly. If ferrosulfate, as I mentioned previously, is necessary at all, then we administer it prior to artesunate. We give 100 to 200 milligrams together with 5 milligrams of folic acid. However, please put this in parenthesis, because the incidence is certainly lower than 10%. I would even say lower than 5%. Compared to the number of patients, we really only administer iron very rarely. Artesunate is administered continuously for 2 to 3 weeks in doses of 60 or 75 milligrams. During the following 4 weeks, we give 60 to 75 milligrams twice a week. What should we now administer? 60 or 75? You have a question. Every day during the first 2 weeks? Yes, every day. Or even for 3 weeks, depending on how aggressive the tumor is, how the patient feels, how fast the tumor grows and how big it is. If we have our backs to the wall, we'll administer artesunate for 3 weeks without a break. When it's not so urgent, we'll do it in 2 weeks. With regard to the dosage, we give 60 milligrams to patients weighing 50 to 70 kilograms or less, and 75 milligrams per day to patients who are heavier than 70 kilograms. Is it also possible to administer nanoiron? Yes. In place of ferrosulfate? Yes, absolutely.
Wie gesagt, nur eben in der, also die Wertigkeit. Nanoeisen ist mir eigentlich noch lieber.
I actually prefer nano iron, but it is even more expensive for the patients. So price-wise it is difficult, but in principle, currently it still plays a minor role. With regard to IV application, we usually administer 5 milligrams per kilogram body weight for up to 3 weeks.
Bei der IV-Applikation geben wir üblicherweise das 3 Wochen. 5 Milligramm pro Kilogramm Körper.
We possibly repeat this cycle, depending on the progress and mass of the tumor, after 4 weeks, 6 weeks, and 8 weeks. And I will tell you why. We have quite a few patients from abroad, America, Australia. Patients from Europe are more easily accessible, but Americans sometimes have problems to come back to us for more treatment after only 4 weeks. After 6 to 8 weeks, that's okay for them. Our colleagues in America have to cross even higher hurdles than we are faced with here. The Food and Drug Administration regards everyone as a criminal who is not a straight liner and doesn't follow their rules and regulations to the dot. So our colleagues there face major problems in these cases and are more reluctant to try something out of the ordinary. Therefore, they prefer to send their patients here. So, these are the reasons for a possible extension between 4 and 8 weeks. Staging plays another important role, obviously. So, after 4 weeks, you can already see a tumor regress. You do see changes. You will see for yourself when I show you the case reports, patient-independent and individualized.
Patientenabhängig individualisiert kann man das dann sehen, bitte.
How long does the drip take? 90 minutes. And what is the solvent? Sodium chloride? Sodium chloride. And 5 milligrams per kilogram body weight? Yes. How long is the half-life? Do you have an absorption range with minimum and maximum? Yes, for an IV administration, the half-life is around 2 hours. And funnily enough, slightly shorter for IM administrations.
Bei der IM-Gabe ist sie witzigerweise etwas verkürzt.
Really? That's interesting. Yes, also with regard to peroral administration. A colleague asked about peroral administration. I'll refer to that later. Anyway, the half-life is apparently up to half an hour shorter. That would probably be the most effective method. That is surely the most effective method, yes. And when is the maximum of the absorption range reached? After approximately 90 minutes.
So, case report.
So, the case report. A 57-year-old patient suffering from ovarial carcinoma with liver metastases and peritoneal cancer. Such are the patients coming to our surgery. Third-line chemotherapy and under progression. Then she developed ascites. Not too pronounced, but it was there. CA125 was at 1183. It should be below 40 in our laboratory. So she received extra artemisinin, IV over a period of 3 weeks, and subsequently 20 milligrams IM once every 2 weeks. After 6 weeks we checked, made a CT and sonography, and realized the difference. After 3 weeks, CA125 was at 32. However, I must somewhat qualify that statement. In the meantime, she's been enjoying a 16-month interval without progression. The CA125, we still check it because that's part of it, but it doesn't concern me that much, because it also goes up in the event of a serious ovaritis.
Bei einer satten Entzündung von Ovarien, da rauscht auch hoch.
Time and again, we have patients suffering from premenstrual syndrome and ovarian cysts. These ladies also have a higher value. People like to have it tested and see it, and when you show it to colleagues, they're happy. Anyway, if somebody suffers from peritonitis, the reading goes up, although the tumor isn't active. What else was administered in addition? The additional administration, yes, of course, I'm sorry. She was also given gemcitabine, monotherapy. With regard to biological oncotherapy, she was administered selenium, vitamin D, zinc, and thymus peptides. In other words, the classic biological oncotherapy.
Also so die klassische biologische Tumortherapie.
And all this can be combined in one day? Yes. Also as a drip? Also together with vitamin C drips? Yes. Even within 1 hour? When one drip is run through, we start the next one. Do patients then experience an interferon episode? Do patients start shaking? No. We've been applying the Artesunate therapy for almost 10 years now. In all these years, we didn't experience one serious incident. We see hot flushes, but no sudden fall of blood pressure. Nothing. No serious change in the blood picture. Nothing at all. What else could there be? No gastrointestinal problems? No. Only if I administer the therapeutic drugs perorally. That could cause problems such as diarrhea, but even that might not happen. I'm just mentioning it. Many patients come to me and show me capsules they've received from abroad. They can cause wind or slight nausea when they burp, a whole variety of flavors. That's why it was so important to us to receive the drug in as pure a state as possible. The majority of normal preparations you can buy elsewhere are contaminated with various derivates. As I pointed out earlier, Artesunate is the only preparation that is hydrosoluble. When I administer liposoluble preparations and the patient is a bit obese, in other words, the BMI is high, diarrhea is likely. The hydrosoluble preparation is used up, which indicates that there is good activity. But a large proportion of the liposoluble preparation is stored in lipocytes and is released after 5 to 7 days in a big cloud. And of course, I require really high doses. When that arrives at the liver as the first-pass effect, the patient can suffer side effects, such as diarrhea or other problems. How much vitamin C do you administer afterwards? 15 grams. Do you also administer procaine-based drips? Yes. The same day? Yes. You'll already have noticed that we are keen to experiment. Up to now, we haven't experienced any contraindications with regard to combinations of naturopathic preparations. However, it goes without saying that we don't administer everything at once. Over the past years, we've tried the following. Artesunate is the standard, and we've combined it with, say, vitamin C. That was fine. But then we haven't administered vitamin C together with zinc or together with selenium, but rather each one individually, so that we can say, okay, there is nothing. And then we've tried other combinations. Initially a combination of 2 substances, then of 3. We were obviously worried about the protein load with the thymus preparation, but it was fine. Even highly allergic patients didn't suffer any side effects. What is better, IM or IV? What do you say? Do you opt for IV if the patient is seriously ill? Yes, certainly. However, if there's an extensive tumor mass, a highly aggressive tumor, it wants to have water quickly, and so I administer 20 milligrams IM and not IV. With regard to IV injection, is there a certain toxicity, for example with regard to liver values? Do I have to take that into account with liver tumors? Yes, wait and see. It's nothing dramatic. We don't scan it. Liver values can go up 10%, 20%. If gamma GT read 150 previously and then moves up to 400, it doesn't worry me too much. Obviously, I get a response from the organ if there is a hepatocellular carcinoma. In colon cancer or ovarial cancer, normal liver values are extremely rare anyway. So when gamma GT varies, it doesn't matter. It happens, but it's of no statistical significance. Neither did we encounter any cases of bilirubinemia or any such things.
Auch keine extreme Hyperbilirubinemie oder sowas, also das haben wir nicht gehabt.
And if the liver values are already high? In such an event, the patient receives a large dose of Hepamax drib, as well as ornithine-aspartate. Do you administer them together? Yes. We had a patient with a bilirubin level of almost 4. She was my colleague's patient. Dr. Scheller liked to experiment, even more than myself. In the morning, he administered ornithine-aspartate, and 2 hours later, the Artesunate drip followed. There were never any problems. On the contrary, the good lady had a bilirubin level of around 1 within 4 weeks. And how many milligrams did you administer? 2 ampoules. How much does one contain? 2 ampoules are normal. They must not get through so quickly, or the patient becomes nauseous. My wife Sabina knows the answer. How long do we let it run through?
Wie lang lassen wir Hepamax laufen? Bitte?
90 minutes. If you let it run through faster, because the patient is in a hurry, then he or she will flush and become nauseous. Ovarial carcinoma, 3rd relapse, with liver metastases, CA 125. The lady had been administered with 100 milligrams IM for 10 days. Thereafter, 150 milligrams 3 times a week for 10 weeks. You could practically forget her veins. She didn't want the port anymore and had it removed. After 8 weeks, liver metastases were no longer detectable. The local relapse was surgically removed. The patient has now been 12 months without a relapse. Here, you can see the CA 125. Once a month, she receives 100 milligrams IM. Don't ask me why. I don't know the answer. There again, it's learning by doing. We also perform tumor migration tests to identify freely floating tumor cells in the blood. Undoubtedly, you'll always find something, but we cannot bring ourselves to say, right, that's it, we stop the therapy. Then we have here the pancreas NPL, initially locally inoperable. The patient received gemcitabine, initially 3 cycles once every 3 weeks. The tumor didn't shrink. It was at a steady state. This was followed by a slight progress. We added Avastin, an angiogenesis inhibitor, which is to interrupt or stop new angiogenesis. Another 3 shots under this therapy. After 6 shots of gemcitabine and 3 shots of Avastin, the tumor further progressed. We then administered 75 milligrams of artemisinin a week for 3 weeks.
Die Therapie haben wir belassen, haben die 3 Wochen Artemisinin gegeben und dann wöchentlich 75 Milligramm. Der Tumor wurde dann, das war nach 6 Wochen.
After almost 6 weeks, the tumor was operable. The patient was operated upon by a colleague in Landau, in the Palatinate, and since has not suffered a relapse for 11 months now. These are all recent cases. This is another patient with primary hepatocellular carcinoma.
Primäres Leberzellkarzinom war früher Hepatitis C.
He used to be a hepatitis C patient, had been treated, and was virus-free following interferon therapy. And still he developed a primary hepatocellular carcinoma. He was administered gemcitabine and Avastin. 1 month standstill before he became progressive again. The therapy continues, also in combination with artemisinin IV. For 6 months now, we have a stable disease. We carried out a PET-CT, which showed a significantly lower activity. However, since this is a dissemination of the entire liver, chemoembolization doesn't make sense. We don't know yet how this will develop. He receives Artesunate for 3 weeks, followed by a 4-week break, followed by 3 weeks of Artesunate. For 6 months now, we have a stable disease, at least according to the MRT. PET-CT shows significantly less activity. That is the problem with university clinics. PET-CT is authorized and paid for in cases of bronchial carcinoma. But for any other diseases, you have to have a good medical service of the healthcare insurances authorizing these examinations. One such examination costs €1,500 or thereabouts. It is only very rarely authorized. Yes, it is only rarely authorized. But when you think about it, €1,500 is nothing compared to the costs for gemcitabine. You could do 4 or 5 PET-CT at the price for a 1-month therapy with gemcitabine and Avastin, and the health insurance meet the invoices. That's all I have to say about that. Your questions, please. What you just told us, does that also apply to myelomatosis? Or are there other specific points to be borne in mind? We don't treat acute leukemia. To be honest, we have no experience with such cases. Solid tumors, okay. Hodgkin, non-Hodgkin, okay. Plasmacytoma too. But currently we have no experience with acute leukemia. Wouldn't you accept cases of leukemia? Well, if I felt particularly bold one morning, I would. Theoretically, the treatment should work with leukemia. The only problem is that people are all connected to centers. If something goes wrong, you're up a creek without a paddle. I'm not worried that something will go wrong. Not at all. But quite honestly, I'd rather wait for initial results from the medical world, and they can be expected sooner or later. The frequency of publications on medical research has gone up enormously. It will only be a matter of time before you see positive results in this field. Is the treatment also suitable for children? Yes, certainly. What about complications, such as allergies or cardiovascular problems, for example? Up to now, I haven't seen any allergies or shocks. Cardiovascular, there are studies involving malaria patients, and they reveal that the anti-inflammatory therapy has a rather positive effect. Cardiovascular complications, which frequently occur during malarial episodes, tend to improve. We haven't witnessed any complications, but that obviously doesn't mean that they don't exist. Let me go back to malaria and just analyze the biochemical mechanism. I come up with anti-inflammatory processes, and that means it's neither bad for my patient, nor for myself. Just a tip. Whenever a new drip is to be used, just allow only a few drops to run to start with. Then you wait for a few minutes, and if everything is okay, you can really start the drip. Yes. And the drip takes an hour and a half? 1.5 hours. Do you have any experience with sarcomas? Yes, they're moderate to good. And I'll tell you why. It depends on the type of sarcoma and how aggressive its growth is, for example. The more aggressive it is, the better the response. We have a patient with sarcoma and lung metastases who responded extremely well to Artesunate. For those sarcomas which grow very slowly, I wouldn't recommend Artesunate as the treatment of first choice. I wouldn't really use it in such a case. Does it pass through the blood-brain barrier? In other words, can it be used for brain tumors? It should work, yes. So far, we've had positive results. We recently treated patients who suffered brain metastases, and they have receded. Primary brain tumors we haven't treated yet, but we're expecting a patient suffering from glioblastoma multiforme grade 4 who is due to receive Artesunate. Therefore, we'll only have results in a few weeks' time. It's been proven that hydrosoluble substances, such as Artesunate, pass the blood-brain barrier. Liposolubles don't. This is not information from oncologists, but from malaria experts. Many anti-malarial drugs have neurological side effects. They're not exactly rare, and they are quite tough. I know that from experience. Such side effects have not been experienced with standard Artesunate. Could you also expect effects in other inflammatory processes? Yes, in theory. We haven't tested it yet. Currently, we're pursuing the incense trail. Quite a few studies with regard to incense are currently underway. I think it'll be used in the future. The more combined, the better. A single violinist is okay, but the sound of an entire orchestra is certainly something else. And the same phenomenon applies to our therapy. Have intratumoral injections been carried out yet? Yes, we've done that. It was terribly painful for the patient. Initially, we used local anesthesia, scandicane gel, so that it penetrates the tumor. In this case, it was a mammacarcinoma, protruding underneath the skin. So we injected the tumor, but the poor ladies really had to suffer. We have a patient with a male mammacarcinoma. Those tumors are the size of walnuts. So my colleague, Dr. Scheller, initially injected fentanyl, and the patient didn't feel a thing. However, afterwards, he developed massive necrosis, and that hurt him a lot. The injection obviously had an effect, bound to when you consider the mechanism. However, we didn't repeat the process. Are there any substances that are incompatible with this therapy? I must point out that we don't combine anything in one drip. I understand that, but maybe one substance after another? As I said, vitamin C, zinc, selenium, no problem. Also mistletoe. Visural A is a mistletoe preparation that is partly also used in drips. We have a colleague in Bavaria who uses it. So far, he hasn't experienced any problems. We've been more careful. He didn't expressively recommend it, but he still uses it. So, up to date, we haven't experienced any definite interactions with a possible negative effect. The only thing I can think of is the publication of the impairing effect on mitomycin. What effect does the base strip have? Would it be better to discontinue it? I would recommend it. From a biochemical point of view, I would partly cancel the effect. I wouldn't discontinue it altogether, but at least minimize it. Obviously, you can always administer it during breaks. Therein lies no question. That was it. Thank you very much. Please contact the German Society for Thymus Therapy for further information.